Hey guys, Woodruff here. Now let's talk about inflammatory bowel disease. So, inflammatory bowel disease is when there is an inflammation of the bowels, as the name suggests, but this is a chronic problem, and it also is usually an autoimmune or immune-related disorder. So, in other words, the body is attacking itself. So, remember, anytime we have autoimmune, the body attacking itself, it's usually going to have like a periods of where it's getting worse and periods where it's getting better. The two types of inflammatory bowel diseases that you want to know about, one is Crohn's and one is ulcerative colitis. And a lot of learning about inflammatory bowel is going to be learning about differentiating these two. Now, they're very similar, they're similar treatments. It's just their patterns of how they appear, the problems that they cause can be a little different. So just where my nursing focus is might be a little different, will be a little different. It's not might be. Also, I just want to mention that this is inflammatory bowel. There's also irritable bowel, and a lot of times students get these mixed up. At least at my school, we do not teach or talk about irritable bowel. It's a different type of disorder that can have constipation or diarrhea. When we're talking about inflammatory bowel, the bowels get inflamed and there's lots and lots of crap. In other words, there's lots of diarrhea. So that's what you should think about with inflammatory bowel. Risk factors are going to be genetics, diet, stress, smoking, the typical offenders, and then also any GI irritants, so things like NSAIDs, antibiotics, and oral contraceptives. Well, let's try again. Jesus. All right. So general symptoms that we're going to experience with inflammatory bowel. So this goes for both Crohn's and ulcerative colitis, is they can experience diarrhea, abdominal pain, fever, fatigue. So kind of those general GI discomforts and inflammatory symptoms. And then the priority assessments for both these patients are going to be to look for fluid and electrolyte imbalances, especially with ulcerative colitis. We're going to be concerned about anemia. We're going to also look for signs with malnutrition for both of them. Crohn's, they're at risk for malnutrition because of the inflammation that's going on in the bowel. It's in areas that you're supposed to be absorbing nutrients. So if there's inflammation in areas where you're supposed to be absorbing nutrients, this can end up with them having a higher chance of not absorbing nutrients, which leads to malnutrition. Whereas with ulcerative colitis, they can have just such bad blood loss, and they can have such imbalances because of the frequency of stools that it can lead to malnutrition. We also, of course, want to assess their stool or bowel habits pattern. How often are they going to the bathroom? What's the consistency? Is there any blood in it? That kind of stuff. And then want to assess their diet, fluid. I was trying to say fluid and fiber at the same time. Fluid and fiber intake, and as a whole, see if they have any other symptoms going on. Are they having any of those general or systemic symptoms that we talked about? And then because they're having frequent diarrhea, we also want to assess for the rectal area for skin or skin breakdown or any other complications around the rectum. So now let's get into some of these differences. What do you call it? Hold on one moment. Sorry about that, just double checking something. Anyway, so now we're really getting into these differences. So we want to see what are the differences between Crohn's and ulcerative colitis, because again, everything with GI, it's like we're trying to break down what are these subtle little changes or differences for these disorders. So for Crohn's, Crohn's is different in where it affects the GI tract. It also is different in how deep the inflammation goes, and then the complications and things like that. So Crohn's is different in that it can affect anywhere in the GI system. So it could be up in the esophagus, the stomach, the small intestine. It can go into the large intestine and the colon. You're most commonly going to see it in the small intestine, but it can affect anywhere. It has intermittent inflammation. So in other words, it's what's also called patchy inflammation or skip lesions, where you might have a little inflammation here, a little inflammation there. Like it's not in a row. Like it's just random periods, or they're not random periods, but random areas or sections of inflammation. And then for Crohn's, it's also that they're going to have inflammation that goes super deep. It goes all the way through all the layers of the bowel. And it's not necessarily saying that it has to, but in other words, we have a higher chance of things like a fistula because we have this ulcer that is, breaking down and going through all layers of the bowels. Additionally, like I mentioned before, we're going to be a little bit more concerned about malabsorption because they're having inflammation in areas where they're supposed to be absorbing nutrients. So less nutrient absorption is happening. And so with ulcerative colitis, on the other hand, instead of being any part of the GI system, ulcerative colitis, like the name suggests, is just in the colon. And so, when it's just in the colon, it's not the other thing that's different about it is it's just in the colon and it's a continuous inflammation, or in other words, there's no like skip lesions, there's no patchy lesions. It's just straight up inflammation. And instead of being in on the through all the layers or being very deep, this is a very superficial inflammation. So it's just inflammation on the innermost layer, the layer that comes in touch with everything like stool, etc. And it's what's called the mucosal layer, and that's going to be where they're going to have their inflammation. So Crohn's is anywhere, intermittent, and deep, and ulcerative colitis is colon only, continuous, and superficial. So just that one layer. So the other thing that's different with ulcerative colitis is going to be that they have bloody diarrhea. You have to think about if there's an inflammation of that superficial or mucosal layer, they're going to be more high risk for bleeding because there's a lot of blood vessels on that layer. And then as a result of this, they're also going to be at risk for anemia because of the the loss of blood, because these people are not just having just having a bowel movement or two or occasional bloody diarrhea. They can have up to 10 to 20 stools per day. So compared to Crohn's, where Crohn's, they can have frequent stools and diarrhea and things like that. They are going to have diarrhea, but it's not going to be usually as severe or as frequent as it is in ulcerative colitis. The other thing we have to consider is that with the frequency of these stools, the sheer number of them, these people are going to be more at risk for hemodynamic instability. So that means their blood pressure can get really low. Think shock, like high heart rate, low blood pressure, really a lot of signs of dehydration, stuff like that during acute attacks. So here's some pictures that maybe help. So like Crohn's disease, you can kind of see the inflammation here could be all over, where ulcerative colitis, it is this continuous that's just at the end in the colon. And then here's some pictures more close up about showing the depth. So you can see here with Crohn's, they can have this cobblestone appearance. It literally looks like cobblestones that you walk on the ground, like where it's very abnormal patterned, like with divots and things like that in the bowel. And then they can have what's called fat wrapping, where pretty much the bowel is so many layers are inflamed. It's kind of building up additional. It's not like, it's kind of like scar tissue, but it's kind of thickening up just as a result of that inflammatory damage. Whereas ulcerative colitis, this is that bloody one. It's the one where it's just the innermost mucosal layer. And you can see there's not the fat wrapping or the cobblestone appearance for this one. So in my class, I was just encouraging, this is a great time to start making a table and start saying okay, all right, I just got a bunch of information. Let me write this down and organize it in a way. And I told you a couple ways you can think about it, but always work with always think about what makes sense to you when you're breaking these things down. But making tables are a great way to study for GI/GU. So now for diagnostic testing, what we're going to do is, sorry, my cat's jealous. We're going to mostly look at what their symptoms are, but we may do further testing to see what's going on inside. We can do things like barium enemas, colonoscopies, especially for ulcerative colitis. But for inflammatory bowel, for Crohn's, it's a little bit harder because we want to see what's going on in uppers. What if it's in their esophagus or in their stomach or in their small intestines? And we can do an endoscopy, an upper endoscopy, and look at the esophagus and the stomach, but we can't go into that small intestine. So what we do is there's something like this that's called a capsule endoscopy, and it allows us to go in with a camera and start to take a look around and see what's going on inside inside in those places that maybe we can't reach a scope. Additionally, we might do biopsies of the tissues to see what kind of damage is going on, and then doing labs to look for problems or complications from inflammatory bowel, so looking for bleeding, again, because they have that risk for anemia, especially with ulcerative colitis. So remember, greater than 12 is normal, and we don't transfuse until they get to less than 7-ish. We want to look for infection, like with a white blood cell count, because this person could be at risk, especially with Crohn's, to having that what do you call it, perforation, and because of the depth of the layers that it goes through in the bowels. And then we also want to look for changes in electrolytes like decreased sodium, potassium, and magnesium with a lot of those diarrhea losses. And then we're going to, of course, look for inflammation because this is an inflammatory disorder. So looking for elevated CRP and ESR. And remember, you don't have to know those numbers in depth, just know that they would be elevated. Additionally, we might do a stool specimen and culture and just make sure there's not something else going on like infectious diarrhea. So inflammatory bowel is better if they're having less frequent attacks or, of the diarrhea, if they're having less symptoms, like abdominal discomfort or the systemic issues like fatigue, fever, that kind of stuff, and no signs of complications. It's getting worse if they're having more frequent attacks or more episodes of diarrhea, more symptoms, such as abdominal discomfort or the systemic issues like I talked about, fever, fatigue, chills. Or we also want to keep an eye out for complications. So again, some of the big complications, malnutrition, anemia, and then we're going to take a break from talking about inflammatory bowel and jump to some of these complications. We're going to talk about peritonitis and fistula, and then they're also at risk for infection like C. diff or toxic megacolon. So this is a picture of a toxic megacolon, and it can obviously get very large and swollen because of the inflammatory process. And this is, by the way, a colon for a horse, not a human, in case you're really freaked out. But I always like to get my students with that sometimes, and just they really think that it's a human colon. They're like, how did that come out of the person? But I'll tell you this, you'd be surprised how big the human colon can get when they get the we call toxic megacolon. So you can see it in like a KUB or a CT and stuff like that, how big it's getting. We also want, like I said, the other complications, bleeding, perforation, which can lead to infection, and then they're also higher risk for C. diff and stuff like that. And then they can be more risk for fistulas, which we'll talk about. So first, let's talk about peritonitis. So this has been like a hot topic we've talked about in a lot of different conditions, but we're going to specifically mention it in this one just because it is one that it's one of many disorders that can lead to bursting of the bowels. And but when it comes to talking about it, this is an appropriate place to bring it up because inflammation of the bowels, and especially with Crohn's, where it can go through all layers, is going to be one of the things you should closely connect with. Like, we have all the other disorders here that we've talked about that it could be. We haven't talked about appendicitis yet, but appendicitis is another one. We've talked about diverticulitis. We've talked about peptic ulcer, anywhere where there can be like breakdown of tissue to the point where we're actually breaking through multiple layers of tissue and can have really serious issues, which can lead to this peritonitis. But let me back up before I get too far ahead of myself. So pretty much what's happening in peritonitis is somewhere in the bowels or in the stomach or, other places, of course, there's a perforation or a bursting of, and usually then it involves like dirty things like stool, or caustic things like bile acids, things like that, gets out into the peritoneal cavity, which is meant to be a sterile area, and inflammation occurs and it can lead to systemic infection. So effectively what's happening here is dirty stuff is getting in a clean area and it can lead to massive systemic infection. And like I said, here's some of the other causes and things like that too. Expected findings for peritonitis are going, and I meant to go back and start this one. So the three like most common things, like, or I would say hallmark signs, are going to be the rigid abdomen, rebound tenderness, and absent bowel sound. So the rigid abdomen, that's like a flat board-like abdomen. Like when you palpate it, it's going to feel like a hard board, like almost like you're touching like a what do you call it, like a tile table. It's going to be very rigid. They can have rebound tenderness. And remember, rebound tenderness is that where we're pushing down, and it doesn't hurt when we push down, but when we let go, that's when it hurts. And then absent bowel sounds are also another ominous sign. So those are kind of your hallmarks of peritonitis. But other things they might feel is, of course, abdominal pain. They can have fever, nausea, vomiting. A lot of times it might even show up as like projectile vomiting, things like that. We're going to, of course, assess for pain, look for that contour, looking for that rigid abdomen, assess for those other symptoms and their bowel sounds, and then looking for signs of infection and shock. So assessing their temperature and then looking for shock in their vitals, low blood pressure, high heart rate. Overall, for peritonitis, what we're going to do is, of course, need to find the cause, what's causing the peritonitis. If there's something that's perforated, we need to close it. We need to clean them out, so we can visualize the problem with a KUB or a CT scan or ultrasound. But usually this patient ends up needing surgery. So think of a lot of the patients that we've talked about: NPO, NG tube. They may need parenteral nutrition. We're not going to put anything in their bowels. They need to be NPO. This is so key, because if they have literally leakage in their intestines, stomach, somewhere like that, it's just going to start seeping out more and more and feeding into the peritoneal cavity. So we don't want that. Managing their fluids and electrolytes, antibiotics to manage that infection, stuff to manage symptoms like antiemetics. They may need pain relief. And they, of course, need pain relief through medications, but we can also encourage them to flex their knees. Again, that fetal position helps. And then, like I said, they're going to go in and usually clean out, or they call it a washout, where they're washing out the abdomen because it's full of junk. And then we're going to be watching their eyes and nose closely and just looking for signs that they're getting better or worse. Hopefully they're getting better. Another complication is fistula. So a fistula is where this sounds like perforation, because there is a connection formed between either two organs that normally do not connect, like the bowel and the bladder. But it also can be an organ in the outside world, like the stomach. So pretty much what's happening here is there's a weak area of tissue. That's probably like, you're like, man, she said a lot about weak areas of tissue. Your abdominal cavity can get very weak, or it has a lot of higher chance of getting weak, or it has thinner tissue. So this is why a lot of these disorders are all about what do you call it? The weak tissue leading to a complication. But anyway, so you have weak tissue somewhere. You either have weak tissue or tissue that's been inflamed a lot, that's just not quite the same. And there is a hole or a tract that forms between, again, either two organs or between a hollow organ and the skin on the external skin. And what happens here is that then stuff starts draining to a place it's not supposed to go. Now, sometimes this might seem harmless, like a part of the bowel, is slipping onto the skin, and so you're leaking some stool onto the skin. What's the big deal? But a lot of times when these happen, where it's going is that there is the bowel and the bladder get connected, like the urinary tract and the colon will get connected. So you're literally leaking stool through your urinary system, or vice versa. And so you end up high risk for infection, high risk for skin issues. And so, it can be hard to manage. Other signs that they might have, I should say, I haven't even gone over these. The signs that they might have are things like an elevated temperature and pain. And then the big thing is you're going to be looking for some sort of fluid, whether it be like their pus, urine, feces in places that normally you wouldn't find it. Like I said, the weak tissue, having a GI surgery, GI disorder, trauma, or cancer is going to put you at an increased risk for getting fistula. We're going to treat it by, of course, like I said, a big focus is on infection prevention, fluid and electrolyte replacement, and monitoring their skin closely, because they can have very severe losses, especially because like this is this new track and stuff's leaking and going where it's not supposed to. We may need anti-motility agents, proton pump inhibitor, things like that. But the big thing you want to think about too is that they may need some special nutritional support, because if they're like constantly leaking stool out of themselves, if I'm just like feeding them, giving them tons of water, like in through their bowels, then like this is just asking. It's kind of like if I was, I'm trying to think if that's a good analogy. It'd be kind of like, I don't know. I don't know if I like it. All right, I'm gonna back off that. I'm not gonna use that analogy, but you'll never know. Anyway, it's just kind of a waste. It'd be like if I had a hole in, let me use this analogy. If I had a hole in a water bottle and I kept trying to fill it up, and all I'm going to do is keep losing fluid from that water bottle because there's a hole in it. So it's the same kind of thing. This is we don't want to just keep pouring stuff in for it to seep out and get lost. So sometimes we have to kind of manage the amount of output that's happening. So in that case, there are times that we do want this patient to be NPO or they might be restricted. Most of these heal on their own, but some do need surgical intervention. And then if they're leaking a lot of stuff, we can collaborate with the WOCN, which is a wound care and ostomy nurse. I wonder if it's supposed to be wound care ostomy nurse. Oh, WCON. I don't know why I have WOCN. Anyway, just my life slowly spiraling and falling apart, no big deal. And yeah, so with these patients, we want to really utilize all of our resources and things like that. Because since they're leaking so much, what the wound care and ostomy nurse can come by and do is they can put like a special bag or something else to help with all of the excess drainage. So medical treatments that we do, a lot of these, now those were complications. So we talked about peritonitis and we talked about fistulas, but now let's get back and talk about, inflammatory bowel in general, and let's talk about what we're going to do to help them. So inflammatory bowels, this is Crohn's and ulcerative colitis. Many times, especially during an acute attack, they're going to need bowel rest. So that means like NPO, we want to, we don't want, if their bowels are inflamed, we don't want to keep putting food in them and things like that. That's going to just make it worse and irritate it. They may need medications to reduce inflammations, things like there's special medications for inflammatory bowel, like 5-ASA, and there's also steroids. We'll talk about those next. There's medications to decrease attacks. Remember, this is autoimmune, so I need to decrease inflammation because it's an inflammatory process, and then I need to decrease the frequency of attacks. So like immunosuppressants, suppressants, biologics. I want to support good nutrition in these patients. So even if they, we'll talk about it, but sometimes they need alternative forms of nutrition. I want to keep a close eye on their fluid and electrolytes because they can have so much loss through that diarrhea they're having. And then especially with ulcerative colitis, I'm going to be concerned about anemia. So this patient may need iron replacement, or depending on where the inflammation is, like with Crohn's, they may have a vitamin B12 deficiency because of the inflammation. They may not be absorbing that. And then surgery wise, a lot of times these patients end up getting multiple bowel resections, and a lot of them end up needing ostomy. So ostomy is the next topic we'll talk about. So let's take a pause and do a question. So a nurse is caring for a client with inflammatory bowel disease that is taking prednisone, which, remember, what is prednisone? It is a steroid. So they're taking a steroid oral tablet for an acute flare. What statement, if made by the client, would indicate that they may be experiencing a complication of this medication? And select all that apply. So we are looking for, one, something that's wrong or bad, and two, we're looking something that's wrong or bad that's associated with oral steroids. So my first choice is, my appetite has been greatly increased since starting the prednisone. So the first question I want to ask myself is this a problem? So with a patient with inflammatory bowel, remember, they have malnutrition or loss of appetite. So this is actually a good thing. I want them to have an increased appetite. Now, with some patients, it can cause weight gain and problems, but for this patient, this is a good thing. I need more appetite, and gaining weight can actually help improve, their prevent complications of malnutrition. So that one I think is okay. B, I have been having intermittent cramping pain in the center of my abdomen. Well, I mean, this sounds like a general symptom that you would have with inflammatory bowel. This doesn't seem like it's actually a complication. It seems like something that's expected, and I don't think it's related to steroids. So I'm going to say this is okay. I've been experiencing chills and developed a new cough. So this is definitely something that's kind of putting some red flags for me, because I know steroids can suppress the immune system. So chills and a new cough makes me think that maybe this patient is having a respiratory infection, which could be a result of the immunosuppression from their prednisone. D is so I'm going to say yes, that is a complication of that. D is I've been feeling tired and having low energy levels most days. So with this one, what I'm thinking here is that like this is kind of like B, where it's like a symptom of having inflammatory bowel disease, but it's not necessarily what do you call it, a result or something from the prednisone. This is something more of a general. So I'm gonna say no to that one. Last but not least, I've been checking my blood glucose and the readings have been higher. So for this one, I'm also going to say yes, it's a complication because the three things I think about with prednisone increases your appetite, increases your blood sugar, and decreases your immune system. So this is another sign of a complication, is just having the higher blood glucose readings. So yeah, so the correct answers here that they're a sign of complication of steroids would be C for the causing infection, and E for causing increased blood glucose. So then getting into these medications, what we want to think about is that we're going to have medications that are going to help decrease inflammation, and then we're going to have medications that help to decrease attacks or frequency of attacks for inflammatory bowel. So the anti-inflammatory medications, this one is a new one that you're not familiar with. We haven't discussed this semester. It's really only used for IBD. Is 5-ASA. It looks like it would be an NSAID, but it's actually not. It's similar, but it's not exactly that. And the purpose of it, of course, is to decrease inflammation. But this is one that's best absorbed topically. So usually we give this one for ulcerative colitis, and we give it via enema. So you can kind of see here, like if we give a suppository, this is how far it goes in. There's foam products that we can use that can go up this area. And then the enemas can actually go all the way up this descending colon. So that really helps because remember, where is the inflammation in ulcerative colitis? It's just that continuous inflammation in that colon area. So this would be great for ulcerative colitis, but then you think about, okay, but where's inflammation for Crohn's? Well, it's higher up. So things like oral meds would be a little bit more what do you call them, effective for those patients. There's also steroids. And again, steroids, we're worried about the immunosuppression. We're worried about high blood glucose, but we are glad that it can help with weight gain. And we can give steroids, suppository, enema, foam, oral, or IV. And remember, with all steroids, they must be tapered or slowly weaned. The other medications to decrease attacks, these are very similar to stuff we talked about for all the other autoimmunes we've talked about, like rheumatoid arthritis, etc. There's going to, and I don't even have specific meds here listed. You do not have to know these in depth. Just know immunosuppressants are another option. There's also biologic agents that modify your immune system. It can be helpful. They help to prevent attacks, so you don't have as many attacks, because again, this is the body attacking itself. But as a side effect, these all usually have a effect of bone marrow suppression, or they decrease all of your cells. So low platelets, low red blood cells, and low white blood cells, which puts you at risk for infection, risk for bleeding, risk for anemia. Then we also want to teach them the stuff because all these are going to suppress their immune system. We want to make sure that we are teaching them how to prevent infection because they're going to be very high risk. So hand washing, avoiding crowds and sick people. As the nurse, the best things that I can do to help a patient with inflammatory bowel is to support really good nutrition for them. So like high calorie, high vitamin, high protein is going to be the diet that I want for them. The book used to talk about a low residue diet, and I'm still going to talk about a low residue diet because it is a generally a well accepted diet. But what the new textbook is really focusing on is a more holistic approach or an individualized approach where it's like what's best for this patient as a whole, like what diet is good for them based on their own individual needs, their own deficiencies. I might not do other things like do a daily weight to make sure that they're gaining weight. One thing to kind of keep in mind with this patient is that we want something that's different because you would think with inflammatory bowel, they what do you call it? With inflammatory bowel, they usually you would think you would want not, I'm going to try to get a sentence out here. Let me try one more time. With an inflamed or inflammatory bowel, you would think that you would want to put them on parenteral nutrition because it would help to let their bowels rest and stuff like that. And we do generally want to put them on bowel rest. But what we do use sometimes now this is something new in the new textbook, is that now they're actually suggesting, oh my goodness, I think these videos are now going to start falling apart. I swear I can speak English like 70% of the time. But they may need enteral nutrition, and that's what they're suggesting now is instead of parenteral nutrition, because they said like parenteral nutrition can lead to it could lead to, you could get a paralytic ileus, and it can actually sometimes make things worse if you're not putting anything in the bowel. So what they suggest now is enteral nutrition. They like the liquid, high in calories, it's high in nutrients. They want one that's lactose free, easily absorbed. So we don't want anything that's going to stress out the bowels. But again, it's kind of this move away from, hey, don't put anything in the bowels versus we would ideally like them to be able to eat, but if we can't, we don't want to go to the parenteral nutrition or the IV nutrition. We want to actually put them on the liquid enteral nutrition wherever possible. Want to keep the skin clean and dry because again they can have a lot of diarrhea and things like that. Maintain their comfort and dignity, and then just know that a big part of inflammatory bowel teaching and education and focus for this patient is stress reduction. So whether it's getting more rest, exercise, support groups, finding meditation, finding ways to take care of self, any sort of stress reduction that we can do. We want to help this patient and connect them with resources. So last but not least, let's talk about a low residue diet. So a low residue diet is also known as a low fiber diet. So again, this is a diet that is commonly used with a lot of inflammatory bowel patients, but just know that every patient, again, probably is going to have more of an individualized approach. So when you think of low residue diet, what you should think of is less residue is less leftovers in the bowel. So there's a decreased risk of irritation or inflammation. So these are foods that are going to easily pass through, not cause a lot of irritation and move on. Things that you want to think about are any of the white products like white breads, white rice, cereals, especially low fiber cereals specifically. Things like pasta, meat, and fish, like protein is going to be good. Whereas things we want to avoid are going to be whole grains, nuts and seeds, fruits, and vegetables, as these are going to hang around and can cause irritation. All right, I think that's it. So that was inflammatory bowel. I know that's a longer one. We're getting there. The next topic is going to be ostomies. See you for that one.